Good morning, everyone. It's been very nice to be in Bern this week. And I'd like to, really at the start, just to thank STC, Jack and Suzanne and colleagues for hosting us here in Bern for our Esther Alliance meetings. It's a partnership between a maternity hospital in Cork in the west of Ireland and the Omdurman Maternity Hospital in Sudan. I know Mayma here from our board representatives from Sudan knows this well. And this partnership over a 10-year period, during the lifetime of the partnership over 10 years, the maternal mortality in this hospital reduced by 86%. And so it's one we look at a lot to try and understand, well, what makes a partnership effective? Now, we're not saying that everything, all the improvement is down to the partnership, but we could see the partnership had a role in that. And this is a very challenging environment. It's possibly the busiest maternity hospital in the world with 36,000 births. It's a high-risk environment because women sometimes only come to hospital when there's a complication. So what was it that worked through the partnership, and what were they doing? And these are the things that we will do in most of our partnerships. It's training, it's capacity building. So people from Sudan coming to Ireland for short periods to upskill in different areas. It's people going out from Ireland to Sudan to do training. And it's training across very multidisciplinary approach, not just training of nurses, doctors, but training across the whole team of people who are involved. It's also about information and research, and we were fortunate in the Omdurman Hospital. They have had records kept for 50 years of every birth in the hospital, so that's a very rich source of data to be able to do research, and that research was very useful in informing some of the decisions about how to improve care in the hospital. And then providing equipment, and we have the opportunity in Ireland where equipment is replaced while it's still good quality, and we're able to pass on some of that equipment. So there's lots of different activities that can happen through our partnerships, and together this has contributed to some of the improvements. Another example this is an example of a collaboration with the training programme, and our Royal College of Surgeons in Ireland has a collaboration with the College of Surgeons for East, Central and Southern Africa. And this is just to highlight a different type of partnership. Our partnerships aren't all hospitals, they can be also other types of institutions. But this partnership is important in the context of training surgeons in Africa. And it's quite interesting if you look at the context of surgeons in Africa. I used to think up to recently that, well, I know that, I think most of us know that most surgeons from Africa are not in Africa, they're in other parts of the world. So I thought that most surgeons who train in Africa leave Africa. That's not the case. The reason African surgeons are not in Africa is because they didn't train there. They did their medical training and then they had to leave for specialist training and then they didn't go back. But if you look since 1974 in the countries of COSEXA, they've looked at where the surgeons who trained in Africa, in those countries, are today. 85% are in the countries that they trained in. 90% are still in Africa. So it just confirms to me the importance of supporting training in countries, not to encourage people to come out. And this is what this program is doing. This is a credit to COSEXA. It's not the College of Surgeons in Ireland. But the College of Surgeons can play a role. We have learned in Ireland about running surgical training programs. We can share that knowledge. And now the COSEXA runs a training on a par with what we do in Ireland. It's not an inferior training. It's the same standard in those countries, but much more relevant to the countries themselves. So just to give you another example, and this is the way we work in Ireland now, is we're a small country like Switzerland, and we can't work in 100 countries, so we're increasingly wanting to focus on countries where we feel we can have most impact, and there are particularly countries where our aid program is involved, supporting the health sector. So as an example, our health service signed an agreement with the Ministry of Health in Mozambique in 2014. And under that agreement then, we're providing support involved with support and training and capacity building across a number of hospitals. And the approach is very much about they identify the needs. We don't set the agenda. We wait till they say this is an area we'd like you to support with, and then we come in and work with them on it, and they asked us to work around quality improvement in hospitals. So they selected teams from from 15 hospitals, and we organised a training programme very similar to what we do in Ireland. And they addressed quality problems in their own hospitals. And there's just a few examples. Each hospital identified what its problem was it wanted to address through the training programme. This hospital was concerned about waiting times, and following the training and interventions that they've brought down waiting times, using the same approaches to analysing and assessing and measuring quality that we do in Ireland. Another hospital was concerned about the very high mortality among sick patients in the medical wards, and they introduced an intervention based on an Australian model called Between the Flags, introducing some very specific measures to assess the care of very sick patients, and a very significant reduction in mortality in the hospital as a result. Another hospital was focusing on medical records. Another one, it was, again, about emergency department waiting times. So the idea is that each hospital will identify its own needs, and I think that's a feature of, and one of the advantages of having these institutional partnership relationships is that you can be flexible. You might be addressing one problem today, and then they'll come and say, oh, we have a problem in another part of the hospital. And having that institutional relationship allows people across the hospital to get involved. And it also embeds the changes then in the hospital, because the hospital at the highest level is involved and supportive. So just moving on then to say about how we organize ourselves in the Alliance then to support the work of the different institutional partnerships. In the last few years, we've strengthened the organizational arrangements. We've now got a strategic framework for 5 years that sets out what it is we're doing, that it encompasses our mission, who is it we are, what are we trying to do. And with that then we also developed a board, and each member country then is represented on the board. Matthias touched on the issue of quality. This is fundamentally important to what we do. And I think you made a very good point that, the people are doing partnerships anyway. So in Ireland, I see that, and people across the health service have links and engagement with different countries. And that's great, as long as they're doing it to a good way. And many times people are well-meaning, but what they do is not necessarily effective or sustainable. And so we very much encourage people to not just do things as individuals, but to try and do things through their institution and to build institutional links, because that's a much more effective and sustainable approach. And in order to guide people around that, we use the Esther tool of Charter for Quality. And this has been developed over a number of years from our experience of what makes a high-quality partnership. So often we think of the project we're doing. What is it, the work we're doing? Well, we say, yeah, the work is fine, but actually for that work to be effective, it's the partnership strength is what will make that work effective. And what do you need to have a high-quality partnership? So I would encourage you, if you're not familiar with this, is to have a look at this and see. In Ireland, what we do, if institutions want to get support from our Esther program, we expect them to be committed to the Charter for Quality. It's completely for them to decide what they do in their partnership, but we want them to do it well, and we believe these principles and approaches is very important for that. So our strategic framework describes what we do. I think this is now will be familiar to you from what you know already, that now it's a range of different types of institutions involved, all following these quality principles. It's all about capacity development, and that can take a lot of different forms, and it's across a wide range of intervention areas. And that then will hopefully all lead to good health outcomes. So just to touch then on a couple of aspects of our plan, and this is where we seek to kind of add value as an alliance and for each of the country programs. Our first goal is around evidence and effectiveness, and Matthias talked about that. I mean, this is so important to us because people will constantly challenge us. Well, how do you know what you're doing is effective? And as you pointed out, when we looked at the literature, we found there's not a lot there of evidence that we can stand over. So we've been very concerned how to develop tools and methods of assessing what we do that show the effectiveness of what we do in our institutional partnership, but also the whole partnership model. Is that the best way of working? Is it better than just sending over consultants, providing technical assistance? And in the next session, you'll hear about the EFFECT tool that we've developed, and yes, which is a self-assessment tool that helps North and South partners look at what they're doing to see if it's effective. So I won't say more about that since that's going to be covered in the next session. But this is, I think, one of the most important pieces of work we've done in the Alliance is to develop tools for measuring the effectiveness of our work. Another key area for us is collaboration and coordination. I mean, this is very important in the whole health agenda anyway. We should always coordinate what we do in countries. But we think that there must be value as an alliance in what we can do by working together. And in order to do that, you need to know what everybody's doing. So we've invested a lot of time and effort in the last year or so to develop an online collaboration platform. So each of the countries in Esther provides information about their partnerships, and so that you can then look at the platform and you can see who's working in which country, who's working on HIV or maternal health, what are the types of projects. And we hope that that will lead to more collaborative work, better coordination, new opportunities maybe of working in joint projects, that kind of thing. The area of advocacy and communication it's our third goal, and this is also important, that we need to, if what we do is effective and important and relevant, we need to be able to communicate that well. And I think sometimes we find with our donors that it's not always apparent to them what we're doing. A lot of our donors, they work at the national level with health policy and health systems, and then they see us working a lot with different institutions, and they say, where does that fit in, and how do we know it's useful? So I think we've quite a bit of work always to do around communicating that more effectively, and that was part of what we were doing yesterday around looking at our theory of change. So we've been working since last year on this question of how do our institutional health partnerships contribute to universal health coverage and sustainable development goals. So we have our partnerships, we have a goal, but how do we get there? There's all sorts of different ways. We're all doing different things, and it should all lead up this way. But are we explicit about this? Do we have a common understanding of how we get there? What works? What doesn't work? What are the assumptions we're making? And this increasing, we're finding this is being asked for. Donors are saying, what's your theory of change? So at one level, we think we know what we're doing and why we're doing it. We say, yeah, we train people, they have better quality of care, better health outcomes. It's clear, isn't it? It's not quite as straightforward as that. And so we've been working on this. And just to say for those who are maybe not so familiar with working on theories of change, it's an organizational roadmap. It's saying, how do we get from where we are with our partnerships to where we want to get to? And it's about a series of change pathways. What needs to change along the way? If we're going to improve better health, things in the institutions we work with need to change. So what are the steps? We provide some inputs, we do activities of different types, certain things change that lead to outputs, outcomes, and we need to understand that well for improve our work and to plan it. So this was Esther Switzerland here, and Luciano and Suzanne and others were involved in helping us to start looking at this. What does it look like? And this is sort of the basic framework that our partnerships lead to strengthening health systems, universal health coverage, SDG 3. And this now in Ireland, we're working on this, and this is just an early draft of what a theory of change for us might look like. So this isn't anything that's been agreed. But it's trying to set out in a very explicit way to say this is how we believe what we do is changing things, and it's leading from where we are to where we want to get to. And there's something then that we can then share with our donors that will help them understand what what we're doing is effective. So the last, I think, just the last probably thing I want to just touch on, just a couple more things about the way we organize ourselves, just so as you understand that. I mentioned about the board. We have each member country sits on the Esther Alliance board, but we have one additional member who's a southern representative, and that's Omeima, who's here, and she fulfills a really important function on our board. We believe partnership is about equality, and we cannot do our work effectively if we don't have a strong voice from our southern partners. And so we added a seat on the board, particularly for that purpose. So it's really important where we're working with southern partners that we know what their views are about the way we work. We think one thing, they sometimes think a different thing, and we need to hear that. We need to know how to support them. They have needs. How do we know, how can we respond to the needs? We need to know what they are and hear what they're saying. We need voices in Africa to advocate for the institutional health partnership approach and encourage others to engage in these type of relationships. There's lots of potential for more partnerships. So it's a very, very important function on the board, and I think we need to make sure in our partnerships, I mean, we all talk about partnership and are committed to equality of partnerships, but sometimes what we do doesn't match what we're trying to do. And a lot of what you hear about partnership these days is not real partnerships based on equality. And I think, Matthias, I think it was you touched on the idea of reciprocity, that this is very important in the Esther Alliance, that we see partnership is a two-way process. It's not just about low-income countries' needs. We all have needs. We all have problems. So we go into relationship recognizing that we each can benefit from the relationship and learn from it. And if we go into that in that spirit of equality, I think that's very positive. So we have the board, and then we establish working groups to work on different areas as needed. And then once a year we have our Esther Alliance meetings where we meet and do more, look at some of these strategic ways of working. So I think maybe that's a good point to finish, and maybe there was one other thing, just to say last year we did some rebranding because our logo originally was reflecting the focus on HIV, so we've changed the logo, but now it's the Esther Alliance for Global Health Partnerships. So we took Europe out of our title because we don't necessarily have to be restricting countries to Europe, but this is our new logo. So I think if I finish there, Mike, just give a few minutes if there's people would like to maybe respond, ask any questions, or make any comments, and just how the Alliance, I think, is about how the Alliance can support what partnerships are doing in countries.